defects. And they may present early or late. And what I mean by that is that some patients will come at the first sign of some distortion. They can be quite aware of the symptoms. Other patients may present very, very late on, actually, when the macular hole perhaps been in there for a long time. It's only when they're examined, they go to their optometrist, or perhaps they accidentally cover one eye that they're aware of a problem with their other eye. In terms of clinical examination, I think I'm really talking about a slit lamp and biomicroscopic examination of the fundus with both eyes with the Volt lens, looking very carefully through the macula. A patient with a macular hole should see a very well circumscribed defect in the center, very well defined borders. Often there's a cuff of subretinal fluid, and typically there are these little yellow spots and little cystic changes around the edges of the hole as well. You will be aware of the Watsky-Allen test, shining a thin beam over the macula, originally described in 1969. It's really about asking the patient to look for any break in that line, so helpful in distinguishing between pseudomacular holes and macular holes. Another little trick is if you shine the beam on the edge of the hole, you should produce a kink with the apex of that kink pointing towards the hole, towards the center. I think that these examination techniques are something that I hope won't be lost. What I've observed over years now with ophthalmic trainees is that they would, in fact, rather look at an OCT than examine the macula. I hope that's not a trend that continues, but we were recently caught out when our OCT machine in my NHS practice started mislabeling scans between different patients. So I think that correlating those signs you can see on clinical examination is very important, comparing them both together in terms of the fundus and the OCT. AMSA grid is very useful for looking at patients with macular pathology. Often they have a small central scotoma or distortion, and also this appearance of microptia. OCT is probably the most useful imaging modality that we have to evaluate the vitreoretinal interface and macular holes. It's useful for the staging and the monitoring of holes also. You can also differentiate between those non-full thickness macular holes, lamellar macular holes, and between cystoid macular changes. You can use other imaging modalities as well, so fundus fluorescein angiography. Fluorescein dye is injected and circulates around whilst pictures are taken. The right side of the slide, you can see in the early stage here, there is early hyperfluorescence at the center of the macular hole. Almost actually observe the early sign of that central cuff fluid as well. Mostly, though, they're helpful in distinguishing between cystoid maculoedema and choroidal neovascular membrane, which can coexist. B-scan ultrasound is helpful in evaluating the presence of PVD or not. Sometimes a operculum can be seen. Very subtle signs such as a double hump can also be seen on patients with a macular hole, although I haven't found that to be that useful. Microperimetry and multifocal ERG have also shown to have success in identifying macular holes. So OCT of the normal macula, and it can get a bit daunting to look at all these abbreviations and the names of the layers there. But I think if we're going to talk about macular holes and the vitreoretinal interface, I think really we're interested in that first couple of layers of the retina, and of course the outer retina where your photoreceptors are. On the left side of the picture, we have identified the posterior hyaloid membrane, so the back surface of the vitreous gel in the eye, and how this interacts with the fovea dip, and that first layer of the retina, the internal limiting membrane. The other thing I like to focus on is not so much the plexiform layer, ganglion cell layer in the middle. It's more this outer retina. So those last 3 or 4 hyperreflective bands seen on the OCT, starting with the ELM, the external limiting membrane. Then you've got your ellipsoid zone, your sometimes called the interdigitation zone, where your photoreceptors are, and after that your retinal pigment epithelium. Shown another way, different scans have different qualities, different machines varies a bit as well. But essentially, those last 3 bands are the ones that we're interested in. Certainly, we think that these are more predictive of visual acuity and outcomes and how well the patient is seeing. Incidentally, going back to that, I think one useful thing to recognise is that you can tell which eye this is just by looking at these scans, and that's looking at the retinal nerve fibre layer that some of you might be aware that is always very much thicker around the optic nerve. So looking at this scan, this is from a patient's right eye. So I think most of you will be quite used to looking at normal OCTs. And when you look at normal OCTs, it becomes much more obvious when OCTs are abnormal, when there are other features. But how do we describe those features? In a full thickness macular hole, there are a few things to point out about this scan here. First of all, we'll start off with the smaller operculum. We used to think operculums were full thickness defects, if you like, that they contained all the photoreceptors. Apparently that's very rarely the case. Mostly they're ganglion cells. On the edge of that is obviously the posterior hyaloid. So I've described this OCT and say, well, this patient has a premacular PVD. Also, again, we can tell it's a right eye because of the thickness of that nerve fiber layer towards the right-hand side of the picture. I've also highlighted the interretinal cystic changes. Some might call that intraretinal fluid changes or perifoveolar changes on the edge of the macular hole. MLD is an abbreviation for minimum limiting diameter. A lot of retinal surgeons like to use this for grading macular holes, and which I'll come on to later on. Essentially getting a feel for the diameter. Most OCTs have a facility for measurement and for finding out how big these holes are. And this minimum limiting diameter is the smallest part of the hole. Down the bottom of the screen, also we have subretinal fluid, this cuff of subretinal fluid that you often see with patients with macular hole on these cross sections as well. So other macular hole appearances, again, we have these perifoveolar cystic changes. We actually measured out the macular hole 697 microns, which puts it into the territory of being a large macular hole, again with a minimum limiting diameter. Also at the bottom, it's got this phenomenon of reverse shadowing. So essentially, there aren't as many retinal layers blocking. You've got your RPE, but after that, there's a hyper-reflective area just underneath the hole. In terms of the pathogenesis of macular holes, we're still very much wondering exactly what it is. We think it's mainly to do with anterior and posterior traction, but there's likely many factors at play. It was first thought to be related to trauma or cystoid maculoedema. In the 1910 and 1920s, we first started looking at histopathology slides and realized the importance of the vitreous. It wasn't until the 80s with Gass in his grading system, he really described vitreomacular traction theory and its association with posterior vitreous detachment. In sort of turn of the century, Yamada described a Muller cell theory of the macular hole. So best described perhaps as if you play sport at a school and you have your small cones that they use to mark out training drills and things. And those cones can be flipped back and forth. The idea is with the right forces at play, a macular hole that's inverted can be flipped outward with inverted edges. Tournamby describes a hydration theory. Of course, you can get a macular hole when you have no vitreous. In post-operative patients, very, very rarely, however, patients that have been vitrectomized can still develop a macular hole. So the hydration theory goes some way to that. The idea is that you have a small amount of traction, which creates an amount of tear on the inner retina, and then hydration occurs from the liquefied vitreous or the liquid that's in the cavity that spreads through the platyplexiform layer, and the ILM is more rigid on top and therefore elevates. I like to describe these OCTs a bit like London Bridge, isn't it? Like a drawbridge that's the bits being drawn up at the top. But I also want to highlight that the vitreous is important, and these firm vitreoretinal attachments are the main reason why these patients get these problems. We don't really know why they get them, and that's still to be found out. My feeling is they probably have a different makeup of their collagen and their gel, and those interactions are different in their retinas. A lot of work is being done on HARLEY sites and how gel separates, how PVDs occur, and why some patients get anomalous PVD where they get macular holes, where they get tears or retinal detachments. The firmest attachments are in your periphery at the vitreous base near the orbis serrata, then it goes to your disc, and then lastly your fovea. And the mid-periphery is probably the weakest kind of attachments that we see. In terms of staging classification, I think these things can get quite confusing. Gass was the first to describe a staging system. Started off, of course, with ophthalmoscopic. He did this off pictures of fundal examinations and not off OCT. So stage 1A and stage 1B are observations of yellow spots around the fovea, either being just spots by themselves or in stage 1B being a full ring, but no evidence of vitreous separation and no evidence of a full thickness macular hole. Stage 2 is a small thickness macular hole, measuring less than 400 microns. Stage 3, more than 400 microns. And at stage 4, there's a full vitreous separation. So how does that relate to the OCT scans that we do today? When stage 1, there is pulling of the posterior hyaloid, formation of this perifoveolar or interretinal fluid cyst, if you like to call it. In stage 2, this ruptures. There's still traction often at this stage, but there is a production of a small full thickness hole. In stage 3, again, the vitreous has separated, or at least there's a premacular PVD. And in stage 4, we grade this as a larger hole. There are other confusions though. So this is technically a grade 0 macular hole, which was added later on. There was, of course, no macular hole here, but you can see some early separation of that posterior sort of hyaloid membrane from the retina, but without the element of traction. So you have to talk about vitreomacular traction then. So on this OCT, the posterior surface of the gel is attached on. Really, to define traction is when there's been distortion or change of those interretinal layers. So when there's retinal morphological changes differentiating between vitreomacular adhesion and vitreomacular traction in this case. There's elevation of the center. There's no foveal dip here. Actually, you can see the edges of this little broad attachment in the center of the OCT. The cotton ball sign is another sign on vitreomacular traction you can observe. It's really a hyperreflective region in the outer retina associated with vitreomacular traction. Often there are small intraretinal cystic changes as well. This is thought to be a poor prognostic factor in these patients with vitreomacular traction. This cotton ball sign should be ones that should be considered for surgery earlier. As things, there are also grades of severity. So vitreomacular traction, as things progresses, cystic changes occur, but also you get a schisis, so macular schisis, a splitting of the retina as the traction increases. Other things to get slightly different confusion between the different grading systems. The way of assessing things is that in picture A, you can either describe this as vitreomacular adhesion or a stage 0 macular hole. In picture B, I would call this vitreomacular traction, but in Gass's classification, this would still be a stage 1 macular hole. So putting them both together, if we use the International Vitreomacular Study Group, stage 0 is vitreomacular adhesion, so there is no pulling, no morphological changes of the retina. In stage 1, there's vitreomacular traction, and between stages 2 and 4, that's the grading for your macular hole. So in that study group, they defined as small less than 250, medium between 250 and 400, and large more than 400. These are all full thickness macular holes with or without the presence of vitreomacular traction. For comparison in Gass's classification versus the International Vitreomacular Traction Study Group. So vitreomacular adhesion progressing to vitreomacular traction, perhaps small to medium size holes, and in stage 4, larger holes with complete PVD. So I'm going to take a short break for questions now. I think that hopefully I'll be able to see them as they pop up, but that might not be possible. I might need your help, Jane.
Right. Well, we haven't got any questions yet.
Okay. Right.
So I encourage people to use the Q&A. It should be at the bottom of your screen, towards the right-hand side. Pop your questions in there. We won't answer. Well, Julian, I can't answer them. I'm ocular plastics. Julian won't. Now, Nisha has raised her hand. Never done a raised hand before, so let's see what it says. Nisha, 2 people have raised their hands. Let's have a look.
Can ERM cause MH?
Ah, good, thank you.
So the answer is it can, but usually it's in the context of vitreomacular traction. So usually you you would say that there has to be some pre-existing on the surface. I don't think an epiretinal membrane by itself is likely to cause a macular hole, or at least a full thickness macular hole, but very, very rarely it could.
Okay, we've got another question here. One of the attendees has said, Diana said, these are great explanations. Could you explain, please, why there may be fluid? The IRCS in the case of macular hole. PS, I think I may have just missed the explanation for this. So you might have said it, but it could you answer that? Why is there fluid?
Sure. I guess that talked about Tournaby's theory of the fact that you've got liquefied vitreous in that cavity. So if you're starting to have vitreomacular traction, if you're starting to have start of your PVD, or at least your premacular PVD, then your vitreous is already in syneresis, is already liquefying. Therefore, there's the availability of that liquid vitreous to enter and go through. His theory is more that there's a small tear in the surface. That's something that hasn't really been proven. But yeah, so the theory is that fluid soaks through the layers, if you like, throughout those layers and down to the bottom.
Great, thank you. Another question. Do we refer for a pre-macular hole? That will probably come up later in your talk, won't it, Julian?
Sure, we can cover that later on, yeah. Sure.
Okay. And then the next one is, when should we refer? Again, we'll come back to those two questions later.
Sure.
Another one on stage 0 macular hole, vitreomacular adherence from Jean-Charles. Am I right in thinking stage 0 MH, brackets vitreomacular adherence, is extremely common?
Yes, I think that particularly in patients that have vitreomacular traction on one eye, it's quite common to look at the other eye and observe something like that. I guess that you'd classify it on how much adherence there is. So there has to be some space around. I think if you look very carefully, I'm sure you're right. You can find some element of early separation there, and not necessarily indicative of running into trouble getting vitreomacular traction later on. But if you observe that in the eye of a patient that already has vitreomacular traction or a macular hole in the other eye, then apparently it is important. They are at risk, and I'll come to that later on. But yeah, said to be, if you've had a macular hole in one eye and you have vitreomacular adhesion on the other, you've got around a 40% chance of traction and possibility of a hole in the other eye.
There's one more question at this point. There will be opportunity for many more questions later. From Ian, would those patients who are at risk of macular hole due to greater adhesion between the vitreous and the macula also be at greater risk of retinal tear, forward stroke detachment?
I don't know. I guess in theory they might be. I think that these are usually patients with abnormal vitreous adhesions, isn't it? It's not normal to not have a PVD where it separates without problems. I mean, okay, flashing lights, traction, and photopsia and floaters and things are normal, but why do these patients get it? I think that probably, if I had to guess, I'd say that they probably are more at risk. Certainly when these patients have surgery, I find it more common to find other abnormal vitreous attachments at the time, if you like. So not necessarily tears and retinal attachments, but odd things going on with the gel. So part of the surgery I'll come to later is inducing the PVD, so pulling the rest of the gel off. There can be some variability in how that happens and how easy it is to do.
So we have briefly lost Julian. Hopefully it's very briefly.
Oh.
Julian, I can hear you. I can hear you.
Good. That's fine.
There's a question, two questions around the cotton ball. One question is, the cotton wool ball reversible, or does it resolve on its own? And the other one on the same topic, the cotton ball sign, is it a deposit or is it a deformation of OS?
Yeah, so the cotton ball sign does resolve. So with release of traction, so with surgery or with spontaneous release of traction. In terms of the composition of it, I don't know. I think I'd more likely say this is a sort of distortion of the layers rather than it being some kind of inflammatory component or something. but I'm not sure.
Thank you. Shall we go on with the next section?
Sure. So moving on to macular hole impersonators. So there are other conditions that can either look like macular holes on clinical examination or similarities on OCT as well. So on first observation of this patient's right eye, in the center of their fundus there, they do have a well circumscribed lesion, which does look quite yellow in color, isn't it? Not just yellow spots and an excavation there. There's a yellow central lesion. Many of you would have seen before. The teleform macular dystrophy would fit with this. The reason I'm including that is that because this changes over time. So initially there's this deposit. It's quite yellow. Often we liken it to an egg yolk that becomes later scrambled. In that kind of middle stage, after the deposit goes down, usually around this time the vision unfortunately starts to deteriorate. It can be mistaken for subretinal fluid due to wet macular degeneration or a choroidal neovascular membrane. There are patients, of course, that end up having injections, perhaps inappropriately at this stage, because there's been a worry that this is a choroidal neovascular membrane. Unfortunately, these patients can also develop a choroidal neovascular membrane, so there is that possibility there, and FFA might help you distinguish between that. Later on, I wanted to point out that in the very, very late stage, when there's marked atrophy, this can also in some ways resemble a hole. You can get the reverse shadowing that I was talking about. It can be difficult to sort of define whether there's actually retinal tissue there. But in these atrophic eyes, although it doesn't look like much, I apologize, it's a smaller picture at the bottom there, but there is still some of the inner retina left there, not just the RPE. So on this fundus photo, it's very subtle, but there are some cystic changes on examination. I think that with cystoid maculoedema, occasionally this can also resemble a macular hole. So there can be on the cross sections, depending on which one you're looking at, what looks like a defect in the ILM that goes all the way down through, but actually they're sort of different conditions. Cystoid maculoedema is a bit of a minefield. I'm often asked, by my trainees to look at an OCT which is cystoid edema. Of course, that the causes of that are multiple, and you need to know a lot more than just look at the OCT. You need to know more about their history, but it makes me think of things like, have they just had cataract surgery? Is it post-operative? Is there a small retinal vein occlusion? Are they diabetic? So on. So some of you may have seen conditions like this before. So there are these defects between the layers. So again, I think the terminology for this isn't that important. You can either define them as interretinal cystic appearances or gaps, or in this sort of case, we're calling this lamellar defects, actually. I don't know if anyone's got an idea of what that is. I'm hoping it's a bit more interactive, but I think we'll might get a little bit complicated. But there are these little yellowish deposits that are also found as well. So this is macular telangiectasia. So typically with this, you get these lamellar defects. So parts of the retina go missing on the OCT scan. There's typically this ILM draping as well. So that first layer of your internal limiting membrane appears just to drape over the top of a nothingness, of a space underneath it. There are these hyperreflective cavities and also these shiny lesions you can see on the fundus examination. And it's characteristically just temporal to the fovea in most cases. So with epiretinal membrane and pseudoholes and lamellar macular holes, usually most people would agree that pseudoholes is probably best reserved for when you're looking at a fundus and you haven't got the OCT. If you like, it's a sort of an anatomical appearance when examining on the slit lamp or looking at the back of the eye. Whereas lamellar macular hole is when you're describing it off on the basis of an OCT. Usually with lamellar holes, there is this steep contour with a coexisting epiretinal membrane. But we think that the lower part of your scan, so the ellipsoid layer, is quite important for prognosis for these patients. Often explaining the minefield of when is best to operate onto an epiretinal membrane, I can't tell you, but I think it's probably patients that have more severe symptoms. If they have progression, particularly for me, if they have symptomatic of distortion with both eyes open, I think it's very significant as well. And perhaps if they have this interruption to their contours of the ellipsoid layer, or perhaps cotton ball-like or ellipsoid layer-like changes as well. So let's get ahead, but in the center of this retina, having a look, you'll see a very small defect, and that can be seen on the OCT as well, in the outer retina around the photoreceptor layer. This is either called a retinal microhole or a macular microhole. They can be patients that have no symptoms whatsoever, and others have a very small central scotoma. We think that anterior-posterior traction, again, with interactions with the gel, are quite important. Also, this can occur post-surgery. So on the bottom left, on scan A, it is a patient that has a macular hole and existing traction. On B, that's the same patient that's had vitreoretinal surgery. They had a vitrectomy, they removed the gel, but there is now this space underneath. It's a bit more dramatic than the OCT, I appreciate, than above it. But actually, as that settles, usually over a few months, it resembles also a macular hole as well. When we see these patients, we often accuse them of looking at the sun or looking at the eclipse, and I've had that very, very rarely to be the case. I think I've had one patient that, said that to me ever, that's admitted they looked at the eclipse. Usually there's something that's picked up on an OCT actually, and they're referred routinely, and the patient hasn't really been aware of anything. The good news is that they stay pretty stable over time, so they don't need treatment. We can't do any treatment for them. A period of monitoring is probably appropriate for a little while to make sure, but after that, they're okay. So I guess, like I was saying, that fundus examination is important in correlation with your OCT. So again, this is a very severe amount of macular atrophy in central areolar choroidal dystrophy. So looking through that center, it's very hard to tell that there are any of the inner retinal layers left, but there are. There isn't just the RPE layer there. Another giveaway, I guess, is this is not related to macular hole, is that there's still, vitreous just on top of that, isn't it? But you still get that kind of reverse shadowing that you do with any type of atrophy. So why would you get a eccentric macular hole? So macular holes are always on the fovea, aren't they? But what if I told you this patient has had macular hole surgery and had successful surgery, and this was identified afterwards? This is in fact a small iatrogenic hole. So in the process of surgery, patients have surgery with staining of the blue dye with their internal limiting membrane. This needs to be peeled away manually with a forceps, and junior surgeons or vitreoretinal trainees perhaps, sometimes you can get these small full thickness defects. They don't detach, they stay stable, they don't need monitoring, but sometimes you might see these kind of effects on an OCT. So move on to secondary macular holes. I guess mostly we've been talking previously about primary macular holes, those to do with traction. Dramatic macular holes, in the first picture on A, shows a chemosis with retinal hemorrhages and a full thickness macular hole. The thing to know about these is that they have a high rate of closure, spontaneous closure. So the feeling is that you should wait perhaps for a month or 2 months for them to close, albeit, of course, if there's lots of commotio and there's lots of hemorrhages, or maybe a small associated amount of retinal detachment, then these can heal with scarring, so vision might not be the same afterwards. But if it's just localized to the macula like this one is, then actually it's probably a better outcome from not having surgery, not having the risks involved in that. Macular holes can occur along with retinal detachment. I see that very, very rarely. The prognosis tends to be quite poor. It's very difficult to fix a macular hole on top of a detached retina. Often more than one surgery is needed for that. There are case reports of causing a macular hole with a YAG laser, so malfocused YAG laser capsulotomy can cause a macular hole as well through injury, direct injury to the retina. They're rarely also described in sickle cell and in injuries with lightning, among other things. I guess with anything, there's always extremes as well. So with Weird and Wonderful, there are giant macular holes. So very, very rare. And I think, again, we're talking about more like case reports here, but very large holes. They've measured the basal diameter in this one, but you might say this is perhaps 2,000, perhaps 2,500 microns. Unfortunately, for these type of patients, there is no treatment. Surgery is not going to improve things. Many things have been tried, I'll come on to later on, but actually the prognosis is quite poor. Also on the spectrum of things here is macular hole retinal detachment. So classic, you'd say that macular holes do not detach, but in certain circumstances, certain patients they can. This was a 17-year-old boy with ocular digital dental syndrome, so very rare genetic syndrome with very high myopia, also had anterior segment dysgenesis and glaucoma as well, had a reduction in vision. They had I think they had pre-existing vision from about 660 anyway, actually, but they'd noticed a shadow that come about. There were no other tears noted. They had a macular hole retinal detachment, which was very difficult to fix. We treat these macular holes with gas bubbles, but unfortunately this patient already had glaucoma and unfortunately did quite poorly. So I'll take another short break for questions then, this time.
Please post your questions on the Q&A. Meanwhile, I've got two questions that are very related. For causes of secondary macular holes, laser toys, laser weapons, do they cause them? And if so, what type and what depth?
Yeah, so I've not seen a laser injury causing a full thickness macular hole, but they can cause defects in the outer retina for sure. I remember a case of a young child who had looks like a photic injury. So they complained of the vision distortion, central scotoma, if you like. They were examined, they had changes on their OCT and a small amount of pigmentary change on the retina as well. And it took a long time to realize that actually they had some kind of board game that was bought from a visit to Japan that involved lasers. So as far as I understand it, there was a laser game where the first connection is through a mirror, and you actually divert the laser very cleverly through a little maze, try and little obstacle course with the laser, but they've been directly looking into that laser at times, and that caused the injury to the eye. So it definitely can cause injury, cause macular hole-like appearances or damage, but perhaps not a full thickness macular hole.
Well, people are very keen to know a little bit more about the management, and I know you're going to come on to this, but just to prepare you, there's one question come through which says, what is the urgency of referral for macular holes? Isn't that going to be a whole section?
Yeah, very difficult question to answer, that, isn't it, really? I'll come to that later on, because I think I'm just going to go briefly through the surgery and the prognosis and the treatment after that, if that's okay.
But the optometrist, that's really the most important question probably of the whole webinar, is when do they refer them on?
I think that
in a minute.
Yeah, I think I would say, I guess at this stage, that any full thickness macular hole should be referred for sure. I think when we're talking about vitreomacular traction, then I think it's reasonable to refer for an opinion for monitoring. I think that there are degrees of that, though, isn't there? There's patients that have very mild vitreomacular traction, that they're asymptomatic, that they've had for a long time, in which case I think it's reasonable to observe. But if I was to define full thickness macular hole, I think all those patients should be referred for an opinion.
And I think Samar was there just now. She was going to ask you a question, but she's now disappeared.
I'm here.
Oh, good.
Yeah, I was just managing the Q&A. There is another question from Ashwin, actually. Is sun gazing, is the damage repairable from sun gazing? What is the vision like after treatment in macular hole surgery as well? Ashwin would like to know.
Yes, so sun gazing, if there's damage, often the OCT changes get better, but the vision doesn't. So if there is changes with scotoma or reduced vision, that doesn't usually recover, and then there is no recovering it. But on the initial injury, often you see hyperreflective areas and pigment changes, they tend to get better. So that's why it's more difficult to figure that out later on what's happened. If you see things earlier, it tends to be a bit more obvious. Later on, you might have that, retinal microhole type appearance, in which case it's difficult to know what went on in the first place. In terms of, sorry. In terms of outcomes of surgery, I'll come on to that later on, so that's okay.
Just to prepare you for the other end of the spectrum of what to refer. So you have already said full thickness macular holes. What about microholes? Will they need to be referred anyway, or can the optometrists monitor these themselves? So if during your talk you can make sure you can please answer that.
Yeah, I guess that when we're talking about the surgery, then these microholes don't need any treatment. I think that if there are symptoms and it's a new occurrence, I think it'd be reasonable to refer them. Sometimes these patients have perhaps been in your practice for many years, and you have the benefit of OCTs from the past. And if that's obvious, or maybe they've been to someone else, they have their printouts of their scans and it's been there for some time, or they've already been seen about it, then I think it's reasonable to observe them. But if patients are concerned, they have symptoms, then I think that getting in pin is reasonable.
Thank you. Let's
go.
Good,
so I'll move on. Good. Yeah, so next part is actually surgery for macular holes, but if I can run that through and I can take the questions afterwards. So when we talk about macular hole surgery, I think it's important to talk about that natural history of macular holes anyway. So there are macular holes, full thickness macular holes that close by themselves, and that really depends on the stage of the macular hole and how large they are. So in stage 1 with vitreoretinal macular traction, you might call it, it can be about 40% chance of them resolving and things settling down and not needing anything else done. When you reach a full thickness macular hole at stage 2, it's around a 15%. This decreases all the way down throughout the stages to large holes with premacular PVD, goes down to around about 5% in that case. But candidates for surgery is still good. So I think that stage 1 with vitreoretinal macular traction, I think that depends on the amount of symptoms, and that will vary surgeon to surgeon. There isn't an agreed criteria, so who should get surgery at that kind of stage, and who should be monitored, and who should have it and who shouldn't have it. But in full thickness macular holes, I think most of us agree that these should have surgery, the exception perhaps being in traumatic macular holes, as I mentioned. In stage 2, I think that in general, actually, I'd probably say the smaller the macular hole, the better the prognosis. So the less duration of symptoms, the smaller the hole, then the better the chance. Even at stage 4, where it's got a very low likelihood of closing itself, you can still get reasonably good success rates with surgery. So surgery for macular holes introduced around 30, 40 years ago, actually. Initially, that was vitrectomy with a bubble, and at that time we worked out about posturing. It's only really later on that we worked out that peeling of the internal limiting membrane was helpful. So we think that this is got good evidence for increasing the rate of closure of macular holes and leading to improvements in visual acuity. There's debate over why this works. Are we just filling a gap in the retina with a bit of ILM? I've often asked that question. I think that the justification is that it might stimulate fibroglial proliferation and facilitate that closure of the hole. So macular hole surgery then, I use 25 gauge vitrectomy, so 3 ports. One is for your infusion cannula, the other is for a very small torchlight in effect. The other is what I call a cutter to remove the vitreous gel, or the pair of forceps that peel the membrane. So it starts off by removing the gel, call that a core vitrectomy, so getting rid of the vitreous. Often with these patients with macular hole, they have not had a full PVD. So we need to induce that during the surgery. So we use a bit of suction to pull the gel off the retina, induce the PVD. Next step is to use a bit of blue dye or internal limiting membrane, or any existing epiretinal membranes need to be relieved. So they're invisible. So although it's technically possible to peel them without dye, most of us use dye to stain the surface to increase the safety of it. Peeling of the membrane can be seen on those kind of pictures there. So grasping the very miniature pair of forceps with the blue dye and pulling a small circle, like a sort of mini rexus, we call it a mini sort of circular peel around that center of the macula. Next is, of course, when you've induced a PVD, there is a chance that you've induced small tears or holes in the retina, so searching around the outside before taking the fluid out of the eye, the water that you used during the surgery, replacing it with an air ball, and later then, of course, exchanging that air ball for a gas bubble of your choice. Again, different surgeons use different gas bubbles. I use a semi-light-acting gas, and there's good evidence for that. That's something called C2F6 that lasts for around 4 to 6 weeks. So techniques for larger macular holes or failed macular holes, holes that haven't closed. Retinal conference is all about new techniques and new methods of fixing things. So can you use an ILM flap? So can you peel a little bit more of the internal limiting membrane and in fact place this over, drape this over the top of the macular hole? Will this help? Justification in many papers is, again, producing these cytokines and factors that will help the Muller cells and help the cohesion of the edges to help close the hole. I've seen other surgeons use platelets, so patient visits, they have the blood taken, they're spun down, platelets are dropped onto the macula at the time of the surgery, which has, again, good evidence for better success rates. Other techniques are aspirating over the hole, so as you're sucking out the air, if you like, to place the gas bubble inside and the fluid inside the eye, should you aspirate any subretinal fluid directly over that macular hole? Later on, of course, some patients resort to silicone or tamponade, so particularly in failed macular hole surgery, perhaps it's their better eye, all things are tried, and silicone oil gives you that extra bit of tamponade to pushes the edges back together for some patients. Post-operatively then, I warn the patients that they're going to have quite poor vision with a gas tamponade, a bubble in your eye. They have form vision, so they can see shapes, but there's no kind of detail. We ask them to do face-down posturing. Of course, that's because gas bubbles float to the top. So a gas bubble in your eye, if I injected it today, would float to the top. You'd obviously have your scotoma at the bottom, but it's your macula that wants to be touched by the bubble to press on it. So they need to position face down to allow the bubble to float into the right position. I advise them about no flying and no driving during that time. It may take up to 6 weeks for my type of gas ball to dissolve away. I also warn patients that they become a human spirit level. So sometimes it can be initially disturbed. There was a wobbly line right at the top of their sight, and they're wobbling along in the first few days after the surgery. After that, a lot of people describe it as seasickness, actually. So as they're walking along the street, they can see the whole world wobbling around them. Often makes them dizzy, so I often advise them to take it very easy when that's happening, particularly when it's at that 50% mark, when it's right in the middle of your central vision, can be quite distracting. Obviously, no driving with that, even if it's a small bubble that's about to dissolve away, because it is in your field of vision, isn't it? Really, it's wobbling around, it's distracting, it's not safe to drive during that time. I'm often asked about posturing and how much to posture. Again, it's an individual surgeon kind of preference. I ask my patients to do 6 hours a day, which sounds a bit of an odd number, but that can be split up. So 6 hours in total throughout the day. It doesn't have to be continuous. They can take toilet breaks. Face down posturing can be more than sort of planking, laying with your head into a pillow, can be one way. I've had patients that have hired massage tables and things and done proper face down like that. But usually we're talking about perhaps resting on a desk or a table. Maybe they can even read or watch something whilst they're doing it. And it's up to them how they break it up throughout the day. I do advise also sort of posturing at night time. I'm laying on the left or the right side, so the bubble's in a slightly better position. But I don't do face down posturing at night. Very difficult to sleep with your face flat against the pillow. But I do know surgeons that do advise that. Yeah. So other things that are a bit more controversial, stage 1B macular holes. So I guess you could say, well, it technically isn't a full thickness macular hole, but there is a defect in the outer retina. So to me, this is a candidate for surgery. They should be considered for. And again, I think I could put it to the floor about what this is. So I think some clues. Initial first thought is that a bit like the ILM draping I was talking about in macular telangiectasia. But in fact, if I told you this patient has already had retinal surgery, this is their third surgery for their macular hole, then this is actually a silicone oil fill. So what you're seeing there is the hyperreflectivity of the edge of the back of that silicone oil bubble just hovering above. And unfortunately, again, this macular hole has failed to close despite the oil bubble. So post-surgery, silicone or tamponade for full thickness macular hole. I am interested in macular holes, and I've done some clinical research on it. We looked at patients that had listed. So in the NHS, there is a tendency, particularly with COVID and waiting lists now, that patients are waiting longer for their surgery. All types of surgery, of course, have been delayed, but do they get worse whilst they're waiting? And the answer is, well, their holes definitely do get bigger. So we looked at 25 patients. We had the benefit of their OCT from the referral, or at least at the point that they were seen in the vitreoretinal clinic. We then did an OCT on the day of their surgery. We broke them up into the classification of size of macular hole, so small, less than 250, 250 to 400, and large being more than 400. And these were all full thickness macular holes. On the left side of the picture is actually the same patient at different stages. On the first picture there, we've measured the minimum limiting bounds, a little bit difficult to see. That's 150 microns, and 91 days later, this was 371 microns. I think what's also something to observe there, to point out, is that the intraretinal sort of cystic perifoveolar cystic change has increased over time. So in general, I think if a macular hole has just occurred, there doesn't tend to be much of that intraretinal cystic or fluid change. Later on, there tends to be lots. And if the holes become chronic over time, actually, it tends to be that there is no cystic change. It tends to settle down altogether, actually. So when we looked at these holes from the day of the surgery, we're calling it baseline, to the, we looked at these holes from the baseline, the time that they were seen in the clinic and the surgery was discussed, to the day of surgery. A lot of patients crossed between those categories. So a lot of patients from the small became large, and a lot of cases between medium became large as well. So there is this progression. In fact, all of the holes in the study got bigger. So we found that the opening diameter, or the minimum limiting diameter, was bigger between all patients over that kind of time period. And that applied to the opening diameter and that base diameter that we sometimes measure as well. It tended to be that smaller holes increase faster than larger holes. There are theories again about why macular holes are large. Again, this hydration theory has to be there, isn't it, really, that cystic appearance, the edges, more fluid, more liquefied vitreous falls through along through the layers, and the edges avert more as the hole increases in size. Also, another theory is that the action of macular hole creates this glial cell proliferation. So there's extra cells that proliferate onto the surface. That gives you, in fact, another form of sort of secondary traction, leading to enlargement of the hole and preventing its closure. So outcomes following vitrectomy for macular hole repair. I think if you were to ask me of any patient across the categories, I'd probably quote about 85% chance, maybe 90% chance of closing a macular hole, not knowing what type of macular hole and how big it is and how long it's been there for. With macular holes less than 400 microns, it's thought to be up to around 94%. So very good success rates of closure of the hole. With larger macular holes, more than 400 microns, this can drop to about 50%. Of course, we're talking about giant macular holes of 2,500 microns. You've probably got about a 0% chance of closing that. So there is a kind of a sliding scale of things, isn't it? In general, it's definitely been proven that you have a better outcome. It might seem obvious, but if you're younger, if you have a smaller hole, and if you saw better to start off with. So next is going to be interactive quiz, but I think we'll take some more questions. I think we had a few questions lined up for the surgery, surgical details.
Can infrared light beams cause retinal holes? This is an old question that didn't get quite answered earlier, as these infrared laser markers are used in a domestic setting.
Not that I'm aware of. Infrared beams? No, not that I've heard of.
How quickly, this is from Katie, how quickly should surgery be done following the formation of a hole?
Good question. So I guess that there isn't an agreed. I think my research was that holes get bigger. So in theory, the smaller holes get bigger faster, and therefore we also know that macular holes do better if they're smaller. So I guess you'd sway towards saying, well, these patients should be referred when they're identified, and this should probably probably not be that routine referral that we expect, perhaps through NHS waiting lists, isn't it? Over 3 months waiting and then perhaps waiting for their surgery after that. It's probably not ideal. For patients that, again, it comes into their history, isn't it? If they've had symptoms for a long time, perhaps they've been asymptomatic or had this for a long time, I guess it's not as important if it's a long-standing, large hole that's chronic. I think that there probably isn't going to be much difference as the timing of surgery. It's definitely been proven that you do better in the first year anyway, if you have your macular hole repaired. I would usually say waiting a few months would be reasonable to get your surgery. But of course, factored into that is their waiting time for the assessment. Often how it works is they're seen initially, then they're seen by a retinal specialist, then they're referred to the retinal surgeon, then they're referred for surgery. So actually, in that time period, there are quite a few delays. So I think they should be referred when they're seen.
That really almost covers what is the urgency of referral for suspected macular holes.
Yeah, I think that suspected macular holes should, again, I think I would still refer them urgently. Yeah, I think that I don't think they're, when I say urgently, I don't think there's something that's going to come over the weekend, are they? And I don't think anyone's going to operate over the weekend, but I think that they should be referred to the eye casualty service and be appropriately triaged. It's usually best that they be seen by a retinal specialist, isn't it, really? So give an opinion, someone that operates on macular holes and vitreoretinal traction. I think accurate kind of descriptions of OCT can be helpful. I don't think the exact terminology actually is that important. People use different things to describe the same scan, really. So some accurate descriptions, but I'll go through what I'd like on referrals for macular holes as well.
Okay, clinically, how can you distinguish between a lamellar macular hole and a full thickness macular hole without the benefit of OCT?
So it can be difficult, but you try your Watt scaling test, isn't it? Shining your thin beam of light directly through the fovea, patient observing for a break of light. I think that, again, let's say you don't have OCT available for you. If the patient is symptomatic, I think it would be reasonable for them to be referred and assessed and have an opinion.
And then another very relevant question here. I had a patient with a full thickness macular hole for about 18 months, and my consultant said not to refer to VR as they wouldn't touch it.
Right. Yeah. So, well, I guess you don't know until you tried, but it depends. I think that the assumption is that if macular holes are very, very large, then their success rate may be less than 50%, and therefore should we not try the hole? I tend to be of the feeling, well, I think that the patient should get to decide that, and I think that if you've got all the assessment done, you measure their hole, you can advise them about the likelihood of success and let them make an informed decision about it. I think talking to the patient and giving them option is important. Of course, there's different levels, isn't it? How many surgeries? If it's a very large hole, will they be prepared to go through 3 surgeries to fix it? Well, I guess they don't have to make that decision initially. It's about coming to that decision. But I would say that
that's where having time to talk to the consultant and go over the options is very valuable, isn't it?
Definitely, yeah. I think that these are best dealt with by surgeons that do the surgery. So yeah, I think that patients deserve a referral.
Will you take one more question before the interactive quiz?
Of course, yeah.
Great. How long does it take for the gas bubble to dissolve? If a patient is experiencing dizziness post-surgery, should they be referred, and how quickly? Does that mean referred to a physician or referred to... Yeah, over to you, Julian.
Yeah, good question. So gas bubbles, it really depends on who does the surgery. So which vitreoretinal surgeon, you'll find a massive sort of variability in this. In the BEVAs, so British Society of Retinal Surgeons, then most popular gas use is the one that I use, the C2F6. It usually lasts between 4 to 6 weeks. That sort of depends on how much fill you get at the start. SF6 is another gas that people tend to use that lasts a little bit longer. That's going out of fashion because that's a greenhouse gas. So I think we're going to be forced in the future to not use that gas, actually. And there are longer acting gases as well.
There's another question which I'd love you to answer. Will patients after macular hole surgery develop cataract as a byproduct of surgery?
Definitely. So I was going to come on to that, but I think that with these patients, it's better to discuss at that time with the should be offered cataract surgery with their vitrectomy surgery. It is very common to get cataract afterwards. You'd probably say in the region of about 90% in the next few years after their vitrectomy surgery, particularly if you use a gaskell like a macular hole repair vitrectomy surgery. So it is a difficult one, and that's why it's important to know their refractive status, really. So I encounter this a lot. It's a difficult discussion to have. I think that this is where, again, it's important to have time to discuss with your patients and maybe discuss it even actually more than once before their surgery. So if patients have, perhaps they're short-sighted, they have some degree of cataract, or they're not particularly advanced, and having a macular hole repair, should you do the cataract surgery at the same time? Of course, when you do that, are you going to correct them for emetropia? In which case, when you do that, they're going to have a significant degree of anisometropia. They're either going to have to wear a contact lens all the time in their other eye, or maybe have cataract surgery early on their better eye. Perhaps that eye is 6'5". I think that those things are difficult to relate to patients. I think they are difficult for patients to understand, and sometimes difficult for doctors to explain them as well. But there are implications for operating and doing cataract surgery. So one way of doing it would be to leave them short-sighted. But of course, with that method, then they've missed their opportunity to have better vision, or better uncorrected vision, if you like, reducing the amount of myopia that they have. So these are discussions that need to be had before. But you're right, I think that a lot of surgeons, particularly like myself, would think about doing the cataract surgery at the same time. But again, it's a discussion with the patient.
Lovely. I'm going to mute, and shall I? Oh, I can do the polling. I'm going to mute. No, I won't. I'm going to bring up the poll. Right. This is your first question. There are going to be 9 questions, and I think Julian will share the results per question, shall we?
We can try and do it that way. You have to bear with me a little bit. So if I move to the first question, then
lovely.
I wonder whether I need to activate the poll or not.
I've got the poll activated at the moment.
Oh, okay.
I think.
Yeah.
Looks as though it is. There's one question and answer. Oh no, we'll come back to that in a minute. I think I have got. No, it's gone and closed. Let me just relaunch it, and it should be activated.
Yeah.
If we have to, now it's activated.
Oh, it looks activated, isn't it? It's gone green.
There. People are voting.
People are voting, right? So the commonest cause of a macular hole.
I think they're going to get it right.
I think they're going to get it right too. Good. So I guess I should define that idiopathic is no particular cause or cause unknown, and iatrogenic is something causing it. Usually, you'd say iatrogenic is a doctor, is a clinician causing a problem. And then there's traumatic and the phototoxic, so light injury or laser injury.
Okay, so I don't know if everybody attending can see the results, but 74% said idiopathic.
Yeah.
A small number, just over 10%, said iatrogenic. And then, of course, there are some traumatics. I think it's reasonable. I wouldn't say it's the commonest, though, is it? No.
No. So most cases, I think we say some people would call them idiopathic macular holes. So they come about through changes of the gel that we don't fully understand. They can be iatrogenic, they can be traumatic, but they're less common. Lovely.
So we've had a very big reply on that. We've had 90% of our attendees vote.
Wow, that's good.
So I'm going to end that question.
Perfect.
Share the results, and now you can see the results there.
Yeah, I can definitely see the results.
Hopefully everybody else can as well. Now I'm going to stop sharing, and should be able to get on to the next question.
I can flip my slide for the next question. So
okay.
Next question is conditions with a similar appearance to full thickness macular hole, and you can choose more than one.
Right, I'm going to launch the poll. Off you go. And no, yes, they're voting. Much wider spread in answers here, aren't there?
Yes. I think it's the multiple choice option.
Yes. Right, we're almost up to 90%. So Julian, do you want to talk about this?
Yeah, absolutely.
Can you see the poll results?
I can, certainly can, and I think I can. I think I've got dual control because I probably share as well.
Oh,
so I think that most popular answers are epiretinal membrane lamellar hole. Of course, this can resemble a full thickness hole in some patients. Macular edema, again as well, on certain types, particularly very severe macular edema can cause it. Geographic atrophy I mentioned before can give that confusing appearance where there is that reverse shadowing and perhaps the appearance of no retinal layers throughout that central bit of the fovea. And vitreoretinal adhesion as well. I think you'd probably say that there are some similarities there. I'd probably say that's one that's probably least likely actually, because I don't think there's any defect in the rest. There's no, if we're calling it vitreoretinal adhesion, there's no traction, so there's no distortion of the retinal layer. So by definition, everything should be normal apart from that adhesion of the vitreous. Good. So let's move on. I think that we're starting off easy and getting harder. So we'll go to the next question then. Question 3. Definitely getting more difficult. Approximate spontaneous closure rate of a very large, let's say more than 400 microns, stage 4 full thickness macular hole. What's the likelihood that this macular hole closes by itself? I guess.
Launch that, Julian.
Can I launch it? Oh, launch, I can do it. Sorry, that's right. Yeah. Okay. So launching that poll now. So what's the chances that a very large macular hole closes by itself?
Very fast replies coming through, and they seem to know what they're talking about.
Excellent. Great. So that's about 89% voted, isn't it? So or in the poll polling there then. If I can share. So yeah, I think that's a unanimous decision, isn't it, really? The message is clear that if you have a very large macular hole, it's probably not going to close by itself. Okay. Stage 4, sorry, big pardon. Question 4. Question 4, what's the approximate spontaneous closure rate of a traumatic macular hole? So traumatic macular hole, what's the chance that it closes by itself without surgery? I'll launch that poll now.
I think 1 or 2 people are still thinking. Yep, they're coming along now.
Getting there, all 91%.
Very high response rate.
Yeah, great. So I'll stop that there. We can share the results again. So I think both the answers are reasonable. I would have said apparently more than 50% actually macular holes can close by themselves, but reasonable standards, yeah, 20–30% of them. It really depends on what kind of study, what kind of population, the severity of the macular hole.
I note here, Julian, you've put large traumatic macular hole. Yeah, so it's not how many of any macular hole, it's large traumatic, yes.
Yes, that's right, yeah. Perfect. Okay, good. So question 5, where are the strongest vitreoretinal attachments?
It's a nice question, isn't it?
Yeah, I think it's an important question. I think this whole topic is about these retinal, these interactions between the gel and the retina. Excellent, good. I think we got to 80, we're at 85% there.
A couple more coming in.
Couple more.
I think we're about there. Oh no, one more. 91% voted.
Yeah, 91, perfect. Good, so share those ones. So you're right, it's the It's the ora serrata. The vitreous base definitely has the firmest vitreoretinal adhesion. There are still more stronger, if you like, adhesions after that at the disc, and the macular disc is thought to be stronger than the macula itself, and mid-peripherally weaker after that still. But it's your peripheral retina that has the strongest attachment, particularly near the aura. Even patients with have had vitrectomy surgery still tend to have attachments there. Is even with the surgery, even inducing posterior vitreous attachment manually, so by aspirating directly over the gel, those attachments are so strong they persist on afterwards. Good, so move on to question 6. A patient with a full thickness macular hole in one eye and a PVD in their other eye, what are their chances of having a second eye macular hole? So they've already had a macular hole in one eye, and they're worried about whether they're going to get that macular hole in the other eye. They do have a PVD. Good. I think we're at about 90%. Yeah, 90, I think it's 91% is about the key number, isn't it? Oh, 94%. Oh, I was wrong. Great. So I'll end the polling and share that. So put this question in to catch you out, isn't it, really? So the idea is that they have a macular hole in one eye. What's their chances in the other eye? Well, if you had a macular hole in one eye, you are definitely more at risk of getting it in the other, except for the case when you've already had your PVD. So if your vitreous is already retracted away, your chance of a macular hole then is very, very low. It's not impossible, but I think on the scale of things, I'd say that that's low rather than being intermediate and high. So I think I'd go with the 22% there and say there's a low chance. So the traction has been relieved, if you like. We're talking that macular holes mainly occur through interactions with the gel and the retina. If the gel has already moved away, there's been a complete PVD, and then the chance is much lower, thankfully.
That was a trick question, but very clear.
It was. Good. Great. So question 7. What is there a better prognosis with which type of posturing for post-operative patients that have had vitrectomy surgery? So what is their evidence for being better? Okay.
There were a couple of people who came in late, Julian.
Ah, yes. I thought we're still going for a record unanimous decision there.
Anyone else want to vote? Yes, they're still coming in. We could do with another 2 or 3 voting. We're up to 87% response at the moment. 89. I'd like to get to 90. Actually, one of the answers there was very reasonable. 91, we're there.
Excellent. So did try and catch you out again. The most better success rate, better prognosis is definitely with face down posturing. I put daytime just to throw in another surprise there, because I think that you can posture face down during the day and lay on cheek at night time. But I think the key thing is that you want to posture throughout the day, not just at night time. Laying on the left cheek may well do something if there's a big, large gas ball at the very start. Doing some posturing at night time, even sitting upright to start off with, will have some element of the gas ball pressing, but it won't last that long. As the bubble shrinks, it will be less and less. And so face down posturing is advised for patients with a macular hole that have a gas tamponade afterwards. All right, good. So question 8. So So we're moving on to OCT questions now. What layer is represented by the arrow? I'm glad that my arrow is still in the same position. Sometimes I think PowerPoint presentations, the pictures can shift a little bit, but it is pointing at the correct layer there. So there's a picture of a full thickness macular hole and what hyperreflective layer is at the bottom.
I think this is quite a difficult question in some respects.
It is. And I think there's more hesitation in the results.
If you had a stopwatch, it's taking a bit longer. A lot of thinking going on. We've come up to a minute now. Shall we stop it?
Yeah, let's stop it now. We're not 85%, are we really? So with the majority, that's correct. This is the retinal pigment epithelium, so the only layer left behind from this full thickness retinal defect. I think that in that centre of that macular hole, there are no photoreceptors left. Just next to it, just next to that cuff of subretinal fluid, there are of course some, but in that centre at the moment, that shiny band that I'm pointing to there is the retinal pigment epithelial layer beneath it going into the choroid. Excellent. So I think this is the final question that we have a poll for, isn't it? Yeah. So what's the most accurate description of this OCT? And again, I think we'll probably split decision there. So out of vitreomacular traction, macular hole stage 1B, stage 0 vitreomacular adhesion, or premacular PVD.
Is it a trick question?
Slightly.
Thank you. Another 15 seconds.
Yeah. Perfect. Okay. Stop that in a minute there, isn't it really? So I would agree with the majority. Again, I think this is a stage 0 macular hole. Now, I think that unfortunately that image is not 100%. So I guess you can mistake us thinking this could be a bit of vitreomacular traction there, depending on whether you think there's a bit of elevation. But technically, this is a stage 0 macular hole with vitreomacular adhesion only and not vitreomacular traction. And there is no premacular PVD. Okay, that's great. So I did have a sort of question 10. Unfortunately, the poll wasn't active for this one. So name the macular hole stage here, because it's a full thickness macular hole, and then this is a stage 2 macular hole. Perfect. Good. So we've gone through the answers to the questions already because we had the poll, which is great. So I'll just skip ahead through these ones here. Great. And we'll move on to the summary. So I think I'll do the summary and then we'll take some questions at the end, Jane. So I think that the message I want to get across is that terminology can be confusing, but I don't think that there are many incorrect ways. There might be different ways of describing things, but there are some kind of key features on macular OCTs to do with full thickness macular holes. In general, though, if there isn't a full thickness defect, then we call this vitreomacular traction rather than macular hole. There's multiple theories about why we develop macular holes, but anterior posterior traction is thought to be one of those main factors. There are other conditions that can look either clinically or on OCT a bit like full thickness macular holes as well. And in general, macular hole surgery carries a good success rate. of closure and better vision should that closure occur. And in general, it's found with patients that present earlier with a smaller macular hole and that started off better to start off with. Macular holes also do tend to enlarge if they're not treated, but occasionally, particularly if they're smaller, can have a chance of it closing spontaneously. So I think if I was going to receive a referral about a macular hole, I don't think there's too much detail that I need, actually. I think that duration is always important for me. So if they've had symptoms, how long have they had them for? And that gives us a gauge of perhaps how urgent things are and how long they've had it for. What's often missed out, I found, is the symptoms. So if patients don't have symptoms, it's often missed out that they're not aware of it. That makes sense. So I think I'd like to know that perhaps it was asymptomatic, it was a routine visit, the patient wasn't aware of any symptoms. So telling me the negative might be helpful as well, because I think that gives probably more weight to the fact that perhaps it's been there for longer. It's maybe been in their weaker eye. They've not been aware of it until they came to visit, until they covered one eye and realised it. Whether there's a full thickness defect is important, and describing that if you've got the ability to perform OCTs, if you have that in your practice. And also their refraction status makes it a little bit easier later on to have that discussion with the patient. So I think I'm happy to take questions and referrals for queries over patients at clinic, and we've got the contact details, and I'll put that slide up at the end as well. What happens when I see a patient though with a macular hole? So they have a full assessment. I think that again, this it's probably split over perhaps a couple of visits where you've got time to talk about the options, and particularly when you're discussing surgery and the complexities of it. I think that they benefit from a more detailed discussion. We do all the standard things. They have a vision, they have an eye pressure check, they obviously have their OCT that's going to help us grade the macular hole, how big it is. I use the little calipers on the OCT software to measure the diameter of it. We look at their refraction, so if we don't have their refraction status from the referral, then we do it for symmetry or even auto-refraction at worst, really. Assessing their PVD status, so usually these patients with macular hole have not had PVD yet, so check for that. And also what status their cataract in. So mostly these are older patients in late middle age. They have some degree of cataract, but knowing how that is on the scale of things is important. I think that patients with no cataract whatsoever may well take a lot longer to develop their cataract after surgery. But again, I think it's a discussion to have. I like to talk about options with patients. So I think that there is always a choice, actually. So if you have a macular hole, you could choose not to have surgery. So perhaps you don't have symptoms, perhaps you're scared to have surgery, perhaps you don't like that risk and benefits that we're talking about with surgery. You could choose not to have operating on. The reality is that probably it won't get better, and if it's a large macular hole, it probably won't close by itself. But patients don't go blind with macular holes. They may not have central vision, may not have reading useful vision, they may have another eye that's very good. Perhaps I've seen it in patients that had an amblyopic eye that develops a macular hole, in which case they haven't noticed it, they're not motivated to have surgery and repair things and take a risk that way. I think ultimately with macular hole surgery, there is that risk of me making things worse. It's very small. I think it's less than 1 in 100 actually. Chance of going blind from vitrectomy surgery, again, I usually quote about 1 in 1,000, so very, very rare. Comes from endophthalmitis infection or a large hemorrhage. I usually talk about their chances of success. So depending on their stage and grade of their hole, then what's the likelihood that one surgery is going to fix this and have better vision. We need to have a discussion about local and general. I think that if we're talking about cataract and vitrectomy surgery, this might be an hour, possibly a little bit longer in certain circumstances. So can the patient lie flat and still for about an hour? Most people actually can, and it's more the thought of it that gets to them. So if they're fitting well, they could choose to have a general anaesthetic. Whether or not we involve cataract surgery, and as I say, I think this might need to come down to assessing their refraction status and their barometry and their sort of expected refractive outcome afterwards. Things need a detailed discussion regarding that. I always talk about posturing as well, so they'll need to do this face down afterwards. Of course, there are certain patients that can't posture, so they have certain neck problems, back problems, that really means they're not going to be able to do it. in which case I guess that, you know, they're not benefiting from it, so perhaps they have a slightly less likelihood of success. Doesn't mean it's not going to work. And also a bit about the expected recovery. Obviously the eye is a bit gritty and a bit red and a bit sore after vitrectomy. It can be very blurry with the gas bubble in there, and it settles down over a few weeks. The best out of the vision is probably when the gas bubble's gone, isn't it? When it's very small, it doesn't get in the way of the central vision very much. You do tend to get all these reflective ideas and reflective things bouncing around the eye. Difficult situation if you haven't done the cataract as well is sometimes that actually they have the macular hole, they have their gas bubble, they can't see. After the gas bubble's gone, they've got a cataract, and then they need to have cataract surgery, and actually it starts a kind of process that kind of way. So that's some references for the details there. So we'll end the talk there, but I'll take some questions again then.
So Julian, is cataract surgery harder post-vitrectomy?
Yeah, I think you'd say that's probably true. Most people, well, it's been proven to be a risk factor. When you remove your vitreous, you could do what we call a core vitrectomy, it's removing the bulk of vitreous and inducing a posterior vitreous attachment. We do tend to leave the anterior vitreous behind, because they're faking. You don't want to get too near to that to disturb it, because you can damage the lens and cause an instant cataract, or even rupture the posterior capsule by doing that. But actually, as you removed it, it does tend to make the zonules weaker and there's less support. So for cataract surgery, it does make a difference. There's less support of the vitreous. So when the cataract surgery starts, we tend to use quite a lot of fluid to give us room at the front of the eye. And that means that there is deepening. So for some surgeons, that's something that they don't encounter very often. As me, as a retinal surgeon, a lot of my patients have already had their vitrectomy surgery or have done it before. So something that commonly happens, you just have to adapt to it, change your dynamics of fluid on your machine and adapt to things. Also, you'd probably say that there is a chance that instruments kind of touch the back of the capsule during that vitrectomy surgery. So there'd be a higher rate of complications for sure.
Do you ever use ocriplasmin?
I don't. Yeah. So I think that ocriplasmin, in theory, then, so this was something that took off quite a while ago, and I think for at least for patients in this country and the surgeons that I know, for retina specialists, is not something that is commonly done anymore. It's hence gone a little bit out of fashion. Ocriplasmin might be good if you have, let's say, a very small hole or vitreomacular traction that's significant, and there's still adhesion, if you like, there's still amounts of vitreous hanging on. And the idea is that if you inject the ocriplasmin, you can dissolve that attachment, and maybe the hole will close or the vitreomacular traction will resolve. The problems with ocriplasmin are that, okay, you don't need to have surgery, but you have to have an injection in your eye. It's quite expensive, so it's probably roughly the cost of having a vitrectomy almost when you count everything together. Unfortunately, there are some patients that, of course, it doesn't work for, and they need to have surgery anyway later on. Also, what worries me more is that it can, of course, induce a proper PVD. So are they more at risk of having a tear or retinal detachment because of that injection into their eye? Yes, they are. So they need to be monitored afterwards. I think in general, as retinal surgeons, we prefer to do surgery, I guess, one way of putting it. We prefer to do things properly and be in control of things. Another reason is, I guess, ocriplasmin might be used more in other healthcare systems. I think it's perhaps more popular in America as well. Something to try first, but there is actually evidence that gas bubbles do almost as well. So if, let's say, instead of injecting your ocriplasmin, you could just inject a very small air bubble. I was involved in a very small trial where we did cataract surgery for patients that had vitreomacular traction, and we injected small air bubbles after the end of surgery. Of course, you haven't removed the gel, so you can't get a very bubble, but many of them did progress on to having a PVD, and some of them did release their vitreomacular traction. It wasn't large enough to draw massive conclusions from, but no, I don't routinely use ocriplasmin.
Julian, I've got 4 more questions. They're quite short. Would you like to stop screen sharing and we can actually see you?
Yes, let's do that.
That would be lovely. So while you're doing that, what is the vision like, and what about colour vision after macular surgery? From Ashwin Popat.
What's their vision like after macular surgery? So I guess we're not talking about immediate post-operative, because when there's a bubble there, you can't see. They've got form vision, but it's very difficult. I think that if you, again, it's difficult. It depends on their original size of the macular hole, their vision, their presentation. It's very variable how much they recover. I think an improvement of about 2 or 3 lines on the eye chart is realistic. Different studies, but you'd probably say around about, let's say 60 to 7% chance if you close the macular hole of having a 2 to 3 line improvement of visual acuity. So these aren't patients that are going to recover all their vision. They're not going to have perfect vision afterwards. I've had very small macular holes that have achieved 6.6 and 6.5, but in general, the larger holes, they're not. So yeah, again, something that needs to be explained to patients, that it's not going to recover 100%.
And then Jean-Charles has asked, do the macular holes that close completely with no hole left, or just flatten themselves?
So I think if a macular hole closes after retinal surgery, usually they remain closed. If you have a macular hole surgery, perhaps with a large hole that fails, usually what happens is the hole gets smaller. So instead of being 1,000 microns, it's now 500 microns. I'm not quite understood that question properly, though. Do you know whether does that sound like I've answered it there, Jane?
We'll move on to the next one.
Okay.
The next is 2 questions only left.
Okay.
Can a macular hole be considered? Oh, Jean-Charles says yes, that's answered. Thank you very much.
Okay, thanks. That's good.
Can a macular hole be considered a retinal tear of the macula? And the pathogenesis, does it differ from a peripheral retinal tear? So it's this link between the two. What is the link? It's vitreous.
Yeah, I mean, I think that they're both abnormal vitreoretinal adhesions, aren't they, really? So yeah, I guess you very much compare the two. I think that with the peripheral retina, when you have traction and develop a tear, it's all about the forces. So the way that your vitreous fibers, your collagen is arranged in the periphery, it's pulling towards the center. Does that make sense? So there's an angle that it pulls around, so you develop a tear rather than a hole. Of course, you can develop holes as well. With the macula, I'd say that they are the same. But because of that force around the center, it is a hole that develops, probably because the arrangement of the fibers, arrangement of the retina around that area.
Great, thank you. Then there's one last question, and I think it's a really super question, and it's a reflection of how fantastic your lecture has been. So thank you very much, Julian. It says, will this fantastic lecture be available for later viewing? It is a lot to digest, extremely useful and engaging.
Yeah. Sure.
I didn't hit the record button from the beginning.
Okay.
So it only records from about slide 4. So I'm going to answer first, and then Julian can answer. I will talk to Samar, who's our sort of technical person, and then at the worst, we could twist Julian's arm possibly to redo the lecture, but it won't have all the chat on it. So it's going to be a choice between, can we release a lecture which doesn't have the introductory slide or not? Let us think about that. But thank you so much for saying that it's a fantastic lecture, and it just echoes what I'm sure everybody else thinks as well. I mean, to me, it was beautiful. It was informative. You're clearly very experienced. And when you showed the little instruments doing that hole around the macula, it is so delicate. I mean, none of us other ophthalmologists do anything quite so delicate as that. So you must have very steady hands.
Certainly do. I think that's probably a requirement, isn't it, of a microsurgeon, of a retinal surgeon. But yeah, thank you very much. That's very kind. I think that yeah, I mean, there is value, isn't it? It's the questions and the answers that come along with the recording, and
I really like it. Yeah, it's very helpful. And we've got a couple here from M. Haroon. Thank you, brilliant. Best lecture of 2021 for me thus far. So I think virtual clap for Julian here. Very definitely.
Thank you very much. Thank you. And
so
I think that hopefully there'll be some more webinars and
Well, we will have. We've got another
lectures and
webinar in
start.
June. We'll be announcing that soon. I can't
Mm.
remember who's doing which one. We may have one in July. We've definitely got one in September. We won't have one in August because I hope everyone will be on holiday.
Sure. Yeah.
Thank you.
Happy to do another one, pick another topic another time.
Julian, you will definitely be invited to do another one, probably
Perfect.
November.
Okay.
Thank
Great.
you. Good evening, everyone. Have a fantastic evening. And thank you for devoting some time, an hour and a half, to be with us here, Clinica London webinar. Thanks. Bye.